There is in the Ministry of Health, they have a line which is receiving call, any call, even from the public, if you have suspicious for your family or one of your colleagues that has taken overdose, whatever, even lynch, paracetamol, ibuprofen, they can take a consultation and they can guide you about where are you going to go or which hospital. Do you know that or not? Okay, we need to do a advertisement for that now. Okay. Just another question. How many of you would you like to be in emergency department? How would you like not to be in the emergency department? Okay. Okay. Like, we are going to approach three topics, or which is paracetamol toxicity, which is the most common, and even cyanide, which is inhaling injury, and the snake bite. Okay, we try to give you some of medical background about or the approach for these substance and poisoning. Okay, how do you know that patient has paracetamol overdose?
History.
History. Okay. What else?
Elevated liver enzyme.
Elevated liver enzyme. Yes. What else? Confusion. Okay. It is part of, at the end, will be one of them. After the patient has liver injury, he will be in encephalopathy. Okay. Usually, in the patient, when they come to the emergency department, they mention that I get paracetamol overdose. They will not be. They will not hide information unless there is a different history. Usually, this is happen with pediatric. When the mother touch the they feel their kid has a fever, and they give him paracetamol every 1 or 2 hours, then the patient will be in liver toxicity, but the mother doesn't know. Okay, and this is why we instruct the family when they give him paracetamol, just be sure he has high temperature, and each 4 hours you give him the appropriate dose. What is the appropriate dose for paracetamol in pediatric? Have you taken pediatric back? Not yet. Not yet. Okay. Okay. In the 150 milligram per kg. You need to say this number when you because one of the medication you prescribe it for pediatric and adult, which is paracetamol. Okay. So 150 exceeding this dose, it might be the patient will be in toxicity. Usually in one dose, 10 gram. Okay? In one dose, 10 gram. I think, do you know how much in each one tablet of paracetamol? How? 500. Okay. Okay, the pediatric patient should not exceed per dose 150 milligram. If the patient has 10 kg, how much you will give him? Yes, this is per dose. Okay, should not exceed this now. If it's the overdose, the main injury is hepatotoxicity, and main antidote, which is N-acetylcysteine. Okay, what is N-acetylcysteine? It's the glutathione. Usually it is in your body, but you need supplemental increasing in the dose. Like, when we're talking about paracetamol, what's happening in our body? Okay, it's coming to you absorb IGI system. It's go to the liver. It's go to two process, which is glucuronidation and sulfation. Okay, and this is two metabolism it doesn't harm the body. It's excreting from the body. But there is small part of the metabolism we'll call this NAC. This is what is called harm for the liver. And when exceed, this is what causes injury for the liver. And even NAC or N-acetylcysteine, when give to the patient, will try to detoxify that NAC. Okay? N-acetylcysteine, it is the main component is glutathione. Okay? It is difficult to understand it or still easy? Okay. This is diagram, just to memorize it, what is called the injury and how is it metabolized in the body. Okay? You see the first one, which is the liver. He's helping your body to eliminate NAC by glucuronidation and sulfation. But small part of it, NAC still is there. But when in overdose, the liver cannot deal with all these NAC. So it needs supplement or it needs more substance, which is N-acetylcysteine. Okay? Easy to memorize it? Yes. Is it clear? Yes. This is stage of injury. Usually the patient when comes to the emergency, we don't know in which stage he's coming. Okay? Some of them, they are worried and come in the early stage, which in the first, within first 24 hours. Patient, he told the physician, I get for those, I take bunch of paracetamol. Okay? And this is in the early stage, which is we would like from the patient to come in that area. When he come in the first 24 hours, we can save him. But if he come late, will end by permanent liver failure. Okay. First stage, he has nausea, vomiting. Second stage, manifestation of liver injury, right upper quadrant pain, high liver enzyme. The third stage, when the patient he coming with high NAR, encephalopathy, metabolic acidosis, and liver failure. And if it's more than 4 days, there is death. Usually in ED department, the patient coming with early stage, yes. The problem with the pediatric, they are coming late. Why? Because the mother, she didn't know she was inducing liver failure for her mother. Okay. But when the patient coming to the ED, we taking history, lab. Okay. What is the specific lab we would like to confirm that patient he has paracetamol overdose? Liver function? No. None. Okay, my question, how can I confirm that the patient has taken overdose? The level? Okay, that means the level of paracetamol. Okay. Okay. When the patient is coming to the emergency, I taken the paracetamol 1 hour ago. This is not helpful for the patient, for me to confirm it has paracetamol toxicity if I do it within 1 hour. I need to do the level at 4 hours. Okay? At 4 hours, I have to do the level. Yeah, when the patient coming to the first 2 hours, even if you do the level of paracetamol, then still I cannot make a decision for this patient. He is in toxicity or not. Okay?
What if the patient comes after, like a few hours after he said he took the overdose?
When?
So for example, he comes to you and he tells you 5 hours ago, I took a bunch of paracetamol.
Okay, at that time you can do it.
Okay.
Okay, but yes, glutathione. What is it? What's your pushing exactly?
I'm asking the reduced level of glutathione after it is consumed by paracetamol.
Use of glutathione. When I measure in the blood, I measure the paracetamol level. Okay. After 4 hours, exactly why I'm doing this, because after 4 hours, I'm be sure if the paracetamol has been metabolized. Okay, within 24 hours is useful, but don't do it the paracetamol level before 4 hours. Okay, from 4 hours to 24 hours, that's acceptable. The ideal way is 4 hours. Okay. Most of the patients, when they come within the first 1 or 2 hours, we do it as add 4. Okay, we'll wait for the patient to do the level, add 4 hours. I hope to answer your question or not.
Yeah, it's clear.
Okay. But let's say if it's after 24 hours, and when the mothers, and in the case scenario, the mothers they give her kids every 2 hours, and she came 3-4 hours later. Is it helpful? No. Okay. Let's make different in decision. Is it clear? Guys, if you didn't speak with me, might be you're not clear.
What do we measure after 24 hours?
24 hours is not will be helpful. It's not because some of the patients when coming with paracetamol toxicity, they come after 1 day. So if you do the okay, if you what is the abnormality you will find it? You will find high INR, high liver function, the patient confusing metabolic acidosis. You cannot make, or let's say the paracetamol level in the blood is not helpful at this time.
Do you look at the symptoms and the presentation?
Yes. Okay, there is one thing I didn't mention here, which is have you ever been used GI charcoal as GI decontamination? Have you even be used it or not? No? Yes, charcoal. Usually, when the patient is coming within the first 1 or 2 hours, we give them activated charcoal. Okay. Activated charcoal, how it help us? It's help us to take the substance outside the body. Okay, it's eliminated. It's very helpful. We recommend it to keep it in your home. Some of you use it for gases. Okay, but at the same time, when the patient coming in the first hour, we give him activated charcoal. But if it's come later, after 2 hours, it will not be helpful. Okay, the antidote is NAC. NAC is repletion of glutathione, as we mentioned that. Even if the patient coming late, after 8 hours or 6 hours or even 24 hours, and we found him in liver failure or he is in complication, let's say metabolic acidosis, it's helpful. At the same time, you arrange for him liver transplantation, but but NAC you can start as soon as possible. The patient comes to you. Okay. At the same time, supportive care for the nausea, vomiting. You can give him antiemetic, IV fluid, and you keep the patient in monitor. Okay. Is it clear, guys? Like, when you give to the napkin, this is the 3 indication you can give the napkin for the patient. When the level above the treatment of normogram, and they will show you the normogram how to use it. Okay, and if it's unknown time with detectable level, the patient sometimes they coming to the emergency, they didn't want to talk to you. Okay, he's upset or doesn't want to give you any information. Okay, so when the patient is coming at this time, it is justified to give him NAC. Okay, the first thing in the nomogram, which is acute, which is our topic today. I really will be happy when everyone know how to deal with acute events. The third one, which is evidence of liver injury, high liver enzyme. This is when the patient is coming with the liver enzyme exceeding 100, okay? Exceeding 100, the ALT and AST.
You're mentioning the normogram?
I am going to, yes, actually, I'm going to show you the nomogram. Is it clear? Okay, this is nomogram. This is how we put it and use it in the emergency department. The patient, when they come, you see that 0, 4, 8, 12, 16, and 24 hours. Okay? The first line is British line. The second line is American line, which is based on the evidence. So, if it's coming in the gray area, which is possible hepatotoxic, it is justified to give him NAC or the antidote. Okay? So, if you be safe, use the British line. Okay? When we count the patient at 4 hours, you see when the level, it is 100 microgram per milliliter. Yes. Yeah.
Can you use the
Pointer. Yes. Okay. You see here? This is 150, right? Microgram. And this is 1000 micromilliliter per liter. Because why this is 2 units? Because different institution will use different units. Okay? Keep you in mind microgram and micromilli per liter. If the patient he's at 4 hours, some of the patient they will tell you I ingested more than 12 grams. But when you do it at 4, you find it in this one. Do you need to give the patient NAC? No. Okay, and some of the physician, if he want to be safe, after even 2 hours or 4 hours, at 8, he will do it repeated one. If it's decline, that will not stop NAC for the patient. But keep as your level. Patient coming, paracetamol overdose, use normogram. How can I use it? This is for the acute ingestion. Clear? Within 24 hours. It's not more than this. After 24 hours, you will not use a normogram. Patient acute ingestion. That means he take at single dose at single time overdose. That means patient he coming to your emergency, he take 10 grams, you will use normogram. Clear?
Doctor, why is it not used after?
Okay, because it's not helpful. Already metabolized. Okay, already make harm for the patient.
Can you give us another example? You asked us and we answered.
Like patient coming with history of 10 ingested of 10 gram, and at 4 level, at 4 hours, he has 300 microgram per milliliter. 300 microgram. Do we need to stop NAC or not? Yes. Okay, I will give you another example. Patient 20 years old female, presented with history of 12 gram injection of paracetamol, and her level at 4 hours 50 microgram per milliliter. No need to give. Is it clear?
Yes. Thank you.
Usually when we decide to do transplant for the patient or make decision, do you know King's rule or King's criteria? Yeah, you didn't know. Okay. You didn't need to go on this level, but at least in the severe cases, when the patient he has liver failure, you need to contact transplant unit for liver transplant. Okay, if the patient reached to liver failure, which is mean liver failure, patient he is encephalopathy, patient he has high NAR and high liver function and high creatinine. You continue in NAC. Okay, I have got one patient. And thanks God, this is a good story to tell you about it. Patient in Al Yamama Hospital. Do you know Al Yamama Hospital or not? Guys? Okay. They presented with history ingestion of paracetamol, pediatric, 3 years old. The mother, she gave her daughter every 3 hours paracetamol. She touched her kid and she gave her paracetamol around 500. Anyway, when they call us in the center, I take the details from the physician. He gave me a good history about the patient. Unfortunately, when she came, she was seizing. Okay, she was seizing. She's seizing, encephalopathy, a high NR, high liver function. Okay, we start NAC, and she presented to ET after 48 hours. Unfortunately, after the NAC, we try to contact transplant unit, but when we give her NAC, we continue for 3 days. The patient has been improved in her clinical situation and in her labs, which is even in the evidence. Even the patient, they mentioned that, even the patient, if he's candidate for transplant, give her NAC. There is chance to be survived. And alhamdulillah, thanks God, she survived. She didn't need transplant. But anyway, it was a very dangerous history from the mother, or dangerous event to do for her kids. And at the same time, it is difficult for the imam to transfer to the patient for another institution, but we continue now. And during that time, we arrange transfer, but the patient, she becoming in good phase. Yes. Sorry? Okay, that's fine. Are you comfortable with it or not? Guys, are you comfortable or not? If you're not comfortable, you can't turn off. Okay.
You want your lights on or off?
Okay, just to remind about the key fact, the toxic dose as acute ingestion was 150 milligram per kg. The level before 4 hours, not reliable. Risk of increasing toxicity, alcohol use, malnutrition, and chronic liver disease. Okay? Malnutrition because the patient glutathione it is a precursor of your body. So if you are in malnutrition, you didn't have enough glutathione. Okay. Is it clear for paracetamol toxicity? Okay. I need a question in the ED for the physician. This. What is the confirmation test after 4 hours? 24 hours. You deal with history, liver function, high now. After the 4 hours, you can use the normogram up to 24 hours.
Is normal is
Yes.
Okay. That's the only thing you order.
You can, no, but you do liver function and INR and the others. And unfortunately, even the patient when he came, yeah, you need to put in your mind the differential diagnosis. So, but the history of paracetamol toxicity is clear. But when you come to the patient to the emergency, you will not do just only the paracetamol. You do the basic screening with it. Any question? Right. Sympathetic mimetic. Okay, we'll go quickly. You know this, which is one of the something that's happened in all the world. It's not in all in our country regarding cocaine and sympathetic mimetic. Just I would like to know how is it the sympathetic mimetics work? It's releasing what? Releasing catecholamine. Okay, this is the word I would like to know. Releasing catecholamine. Okay, and blocks the uptake for norepinephrine, dopamine, and serotonin. What is the mainly as cardiotoxicity? Sodium channel block. Okay, because this is a different management when we come to the management of patient coming with sympathomimetic. It is different from the patient if he comes with VTAC. You know, the management of VTAC in overdose is different than VTAC patient coming with ischemic heart disease. Okay? Clinical presentation: tachycardic, tachypneic, hypertension, hyperthermia, diaphoresis, sometimes arrhythmia and seizure. Rhabdomyolysis, the MI stroke, it might be happen, but unfortunately, and we have seen it in young patient 28 and 23 years old. Okay, usually this is a classic presentation. But when the patient coming to the emergency, unfortunately, he will tell you, I didn't take anything. He didn't take anything. When they come, the patient agitated, hyperthermia, fever. It sounds look like sepsis, right? Yeah, because the patient when coming to the emergency department, the problem in the approach. What does it mean that? You think the patient fever, confused, you think I will do CT brain, lumbar puncture, I give him antibiotics, and I will see what's happened. But unfortunately, with taking more history, you will find his relative and or his colleague, he tell me he take sympathomimetic.
Doctor, do you get a lot of cases like this?
If you work in some institution rather than here, you will find a lot. I didn't want to mention that's the hospital because you know we see it a lot. We see it a specific population they have it. Like what's the main complication? As we mentioned, ischemia, arrhythmia, dissection, stroke, and hyponatremia and MA and rhabdo. Like how is the diagnosis and clinical diagnosis? By the history, guys. Okay, if the patient he doesn't tell you about exactly what's happening for him, you will think about it. The other differential. It is clinical diagnosis. If the patient tell you, I take amphetamine or sympathomimetic, that means you will try different management. You will not give him antibiotics. You will give him another medication, benzodiazepine, sometimes phenobarb, but you will keep your in mind the other differential. Is it urine drug screen is helpful? No, it's helpful in the follow-up, not in the diagnosis. Okay. The other labs to rule out other differentials, like CK, troponin, or you will try to find the complication. Okay?
Why is it not included in the diagnosis?
Why?
The urine test, why is it not in the diagnosis?
In the diagnosis, because it is non-specific, it's non-sensitive. You will take might be omeprazole, you will get fine amphetamine, let's say, test positive. So it is not helpful. It is helpful when you're coming to the psychiatry and he's doing follow up with the patient and he asking the question, are you still taking or not? So, okay, clear? As management, when the patient comes to the ED, we'll give him benzo until he sleep. Okay? We, at the same time, will give him fluid regarding hypertension. And regarding hypertension, when you give him benzo, it's being controlled. I never use phentermine for those patients. Most of them with benzo, it's work. Okay? But keep it as second line, nitro and phentermine.
How do you cool them rapidly? How do you make sure that they're
Cooling, ice.
ice? You get
That's yes. And sometimes with benzo, it's work. Okay? You give him fluid benzo, fine. Guys, if any patient coming to the emergency and overdose, just tell the physician, benzo, they will love you. Okay? Most of the medication or most of the overdoses by benzo, it works. Okay? Okay, for arrhythmia, a patient when coming with sympathomagnetic and have anyone taking cardiovascular system? Have you taken that?
Yes.
How do you treat the BTAC? White BTAC? You didn't take management?
The diseases, pathology, and
Pathology. You didn't take management. Okay. Okay. Let's tell you that. Patient coming with history of chest pain, white QRS, you will manage him as VTAC, which is you are going to give him amiodarone or procainamide. Okay, amiodarone or procainamide. But if he in the history he has tell you I have ingestion sympathomimetic, you will give him benzo and sodium bicarb. Benzo, okay, benzo is great, but sodium bicarb for the white QRS. Okay, because I will give you, this is a question in the exam. Patient coming with white QRS and in the history he has taken symptomatic. Are you going to choose amiodarone or sodium bicarb?
sodium bicarb.
Okay, that's clear. I will not put benzo in the same question, huh? When the patient coming with chest pain, try to treat him as SAS, but avoid to give him beta blocker. Usually, actually, in the emergency, we will not give beta blocker because it shows in our evidence it's increasing mortality. Usually, after the patient is doing cath and becoming stable, they start beta blocker. Okay, here. Okay. Keep the other differential. As we know, patient incoming with fever, confusion, agitation. It might be thyroid storm, it might be sepsis or serotonin toxicity. Okay? Anticholinergic or withdrawal state. Snake bite. Okay. Well, this is topics I think everybody's like it. Have you ever seen a snake here in our country or not? Yeah. Like, usually we get a lot of snake bite, but some of them dry and some of them it's really venomous. But usually in summer months. Okay. What does it mean dry? When I say dry bite. Dry bite, that's the snake. There is no injury in the site of injection. Okay, you will not find the teeth of snake. You will not find swelling. So in such condition, we just need to observe. But always and always keep it to the walls until proven otherwise. Even if there is snake bite, just keep to observe patient rather than, okay, this is simple, you don't know what's happening. Okay. Mortality is low. Why? Because you have emergency department. Right. I will talk about two features of two kind of snake in our country, pied viper and cobra. You know there is different from the feature of a snake. The head triangle, the pied, and pupils. And I will show you the picture to differentiate between venomous snake and non-venomous snake. Okay. Usually the snakes, some of it hematotoxicity and neurotoxicity. This is two types. I will show you exactly about how to differentiate between venomous and non-venomous. Let me see the yeah. When you see here the snake, the venomous snake, which is triangle, okay, non-venomous, rounded head. Usually you see it in the farm, زي الدعية, like الدعية or أمارية. Okay, you will see the rounded head, non-venomous. The venomous, when you go to Thmamad, to the desert, you will see it. Okay, this is really a scary one. I will show you a picture. Regarding the pupils, you see the rounded pupil in the non-venomous and elliptical in the venomous, and at the end the tail. Usually we cannot ask the patient, did you see it, how is the triangle, how is the pupil, because at that time he will be scary, he will not know about it, okay? So, is this information we dependent on the history? No. But as a knowledge, you need to understand how to differentiate between venomous and non-venomous and the area that's distributing it. Clear? Clear, guys? طيب, the corn snake, it is neurotoxic and it causes respiratory failure. I will show you even a picture. This is corn snake. Okay, some of it will be coming in the yellow, red, black. Okay, and this is type of neurotoxic. It is in the not in the central region, in the west and south. Who's coming from Nasir? I think I've seen this snake or Abha. Anyone from here? Nasir Abha? No. Okay, it is distributed in the west region and south. You will not see it in the central region. This is a viper. This is, you see it in Thmama. Have you even seen it or not, guys? Did you see it? No. Venomous, yes, also venomous. This is viper. This is a venomous. Usually it's coming under the ground, and you not see it except the head of the snake. Okay. This is hematotoxic. Also, this is viper, hematotoxic. Okay. Okay, when the patient coming to the emergency, what's his complaint? Local swelling, on the right side. Okay, and sometimes coming ecchymosis, and some of them respiratory failure. The respiratory failure with coronal snake or the Arabic cobra. But this is as clinical presentation, is coming with both local signs and asymptomatic signs. Patient becoming tachycardic, sometimes hemodynamically unstable, blood pressure low, and weakness. Okay, this is coming with both snakes, right? Okay.
I will tell you exactly who I might be tell you about which snake, but respiratory failure will be within with Arabic cobra, but it's coming late. Most of the presentation coming with these symptoms.
And you put the patient on ventilator?
Just let me tell you exactly. Now we'll go to the management. Okay, is it clear, guys? This is the symptoms coming with both. Severity of symptoms depend on the venomous and bite location and patient comorbidity. Okay. When you come to the history, you need to ask about the location of bite. Most of the time, it's coming in the extremity, upper or lower. You will need to know about the tetanus status and the comorbidity and allergy and previous snake bite, because some of them they be current coming exposed to a snake, and you don't want to know if the patient has allergy from the medication or not. As physical exam, you will do a quick exam for them. Usually the CNS manifestation it's coming late, but if you give him antivenom, you will eliminate that. With Cobra Arabic, or that neurotoxic patient coming with ptosis, diplopia, dysphagia, weakness, and paralysis. But with hematotoxic, unlikely to see the CNS manifestation. In the hematology, you will see the thrombocytopenia, coagulopathy, and bleeding. Definitely, diagnosis primary. Okay, not you will do the lab just to observe the patient. But snake bite, it is clinical assessment. Okay, pre-hospital. I think some of you guys listen from their family. You need to suck the venomous, apply it on the gate, right? Have you ever listened to that? Huh?
Yes.
Don't do anything. Okay, don't do anything. Okay, just immobilize them and transport the patient. Unless if there is watcher in his hand or any tight clothes, just take it off. Okay, is it clear? This is an important part in our lecture now. Okay, yes.
Some people they say they have to take this to the hospital. When you recognize it.
Yes, but don't be in dangerous and to take snake. Okay, it might be still dangerous. Okay, just keep it away. Take the patient to the hospital. Don't make a second victim. طيب, as an emergency, ABC usual, and steps, pain control, patient when coming, pain control lab, and pain management, and possible of start antivenom. But let me tell you about antivenom when you get it. طيب, usually at the whole in each country has specific species of snake. So, in the United States, the snake is different than Europe, it's different than Asia, it's different than Australia, and different than from Saudi Arabia. So, we have, and we need to be really proud of that, we have a product of antivenom is generated in National Guard. It's this antivenom for the species in our country. They collected. They make antivenom for this. Okay? So, even hematotoxic or neurotoxic, you just start antivenom. Okay? When we start antivenom, progression of swelling, systemic toxicity. What does it mean, systemic toxicity? Unstable, tachypneic, tachycardic, febrile. Patient he has coagulopathy. Patient he has cross major joint. What does it mean? He gets the pain in the, let's say he gets snake or the bite at ankle. Now he has pain at hip joint. Okay, this is indication for antivenom. No. It should be in the only place that you find antivenom in emergency department. Okay, and sometimes if it's, let's say, you walk in the hospital, they don't have availability of antivenom. You call 1973. They providing you the antivenom. Okay, or transport the patient to another institution to provide him the antivenom. Usually in Riyadh, it is available. Outside Riyadh, some of the hospital. Yes, go ahead.
So you don't always give antivenom?
No.
But what if it progresses later?
You need to observe.
So they stay until they're...
Yes. Yeah. Let's say, okay, this is the patient coming to the emergency department, and you see the snake bite. You will not disturb the patient immediately, everything is fine. No, you need to observe him at least 8 hours. Okay? Then after 8 hours, you repeat the labs and you assess him again. After that, discharge. Okay? If it's dry bite. Okay? Clear?
الوقت ياخذ عنا بس we'll go ahead. Monitor, observe, bite viper 8 to 12 hours. Coral or cobra, this is 24 hours, okay? Because we are afraid about respiratory failure.
Doctor, how do you confirm the species of the...
We cannot.
Okay, so you keep everyone 24 hours.
Yeah. And that's, let's say 12 hours. Because the coral or the snake bite, it is well known and different in Asir. If you go and they by the history, he said that this is snake that it is coral or Arabic. This is, you need to observe him at 24 hours. Sorry, doctor, we have time, I think. As a side effect, hypersensitivity of antivenom, hypersensitivity serum sickness. And if he developed adverse events of our allergy, you will give him steroid and antihistamine and epinephrine. Like, okay. Smoke inhalation. Just I would like to talk about okay, carbon monoxide. You see it, carbon monoxide. Okay, carbon monoxide. No, not suicide. Most of what's happened in our country, they coming in the emergency department, they close the window, they put the fire, especially in the winter, and they try to heat themselves by whatever. Do you see that a lot? Okay, then coming to our department, headache, nausea, vomiting, which is, this is carbon monoxide. How do we confirm it? By blood gas. With CCO, level is high. Usually it's above 10. Okay? But cyanide. Cyanide toxicity, we see it common in the when there is building has been fired, okay, because of plastic consumption. Even it is there in some of the food. Do you know what is?
Seeds of fruit.
Some of it, peach, especially peach, okay? But in the small amount, doesn't mean that you will not eat peach. You can eat it, but it's a small amount. But what's in the building, when there is plastic, you will coming to patient to your department and he complaining about shortness, breath, cough, and how do you confirm it? By the lactic acid. The patient, he had high lactic acid and high level of carbon monoxide. Okay, usually the lactic will be above 10. If you give you a scenario, patient coming from building and there's a fire and lactic acid is high, around 10, this is what
This is a cyanide toxicity. What is the antidote?
This is okay. Before the antidote, it is hydroxychloroquine. I will show you. But I would like, because the cyanide, one of the poisoning has been studied well. If you find any textbook, you will see you will not see unknown mechanism. No, this is well known. I would like from you to just know one thing, which is inhibit electronic transport chain. Okay, so that prevent convert ADP to ATPs. So this is why you find the high lactic in investigation. If it's lactic above 10, this is most likely cyanide, because we'll not do a measurement for cyanide by itself. Okay, is it clear? Clinical presentation, usually high lactic acid, chest X-ray just to rule out other complication. Bronchoscopy, we didn't do it in the emergency department, but this is after admission for the patient. As history, as I told you, here as management, you apply oxygen. Regarding hyperbaric and carbon monoxide, is not doing well. We're not usually we do it. Most of the time is just apply oxygen. Regarding the cyanide, hydroxychloroquine. Okay. If I ask you what is the antidote for cyanide toxicity, which is indication for intubation, just in case the patient coming with for carbon monoxide or cyanide toxicity. Usually we assess the patient airway. We about sure about he is at the level of his consciousness as a signs to early tube him. Why we want to early tube him? Because we don't want to wait until the patient he got edema and obstructing airway and we couldn't deal with him at that time. So usually even those patients, when you go to the emergency, ED physician, they tube them when it is have these signs, which is stridor, edema, hoarseness, drooling, or severe distress.
So before the signs or
Once you see this sign, okay? Stridor, severe edema, drooling, and severe distress. Any question, guys? Sorry, I'm late, 10 minutes. Any question? Allah yawfiqkum. Well, one thing, really, this is the first time we give you a lecture. I'm proud of you guys. You are, since when you come to the college and you see a lot of students still, they have attention and attendance. This lecture, I am really happy about that. And thank you guys for you.